Now we start with the session. May I call upon Dr. Bhushan Valgat, who is currently associated with Sahyadri Group of Hospitals, Pune as a consultant oncosurgeon. He has gained a profound amount of hands-on experience in operating cancer patients over the patients of 7 years. Furthermore, he has attained higher laparoscopy training at World Laparoscopy Hospital, Pune. Sanjay sir, please. Sorry, Bhushan Valgat sir, please.
In front of so many cancers, GI cancers, or usually in general about cancers, how to treat. For the audience is usually general practitioners or consultants. Today the audience is nutritionists, dietitians. So the topic given to me was dysphagia in cancer. I'm Dr. Bhushan Valgat. I work at Sahyadri. Let's start the topic today. So the ability to swallow is something that many of us take for granted. It's a boon for us given by God until we experience this symptom called as dysphagia. This is a very dysfunctional thing a patient has to go through. Yeah, it causes a lot of morbidity in the patient. Even after treatment, the patient is not always very happy. It basically means having trouble swallowing. Please note, you already might know that there's a difference between dysphagia and odynophagia. Odynophagia basically means there's pain during swallowing, and dysphagia means is not able to swallow. So odynophagia could lead to dysphagia, but it's not the reverse way always. What is the physiology of swallowing? Swallowing usually has 4 phases. It's the oral swallowing phase, the oral chewing phase, the oral transit phase, the pharyngeal phase, and the esophageal phase. So oral chewing phase, basically the saliva comes in, the enzymes digest the food, whatever is possible in the mouth, and then it goes into the oral transit phase where the tongue touches the palate and the soft palate, and the food bolus is pushed behind into the pharynx. During this phase, the swallowing is still going on. But during the pharyngeal phase, when the food is already in the pharynx, the epiglottis comes and closes the laryngeal inlet, and the food goes from the pharynx into the esophagus. During this phase, the soft palate prevents the food from going back into the nasopharynx. And in the third phase, which is the esophageal phase, again this inhalation and expiration goes on. The upper esophageal sphincter closes, and the food, due to peristalsis of the esophagus, goes down bit by bit. So if you understand the physiology of swallowing, you will understand dysphagia. So how do we subjectively assess swallowing? There are 2 methods. One is the swallowing efficiency and one is the swallowing safety. So what do we mean by swallowing efficiency is how quickly and effortlessly you are able to swallow. That is subjectively assessment of dysphagia. Inefficient swallowing results that the food accumulates in the oral cavity or in the pharynx, and that is a main symptom of dysphagia. It might take a long time for the food bolus to go down, and the patient usually complains that some food is stuck in my oral cavity or in my throat. The second way to assess dysphagia subjectively, this is not the objective ways. Objective ways will be discussed ahead by the other eminent speakers. The second way to subjectively assess is swallowing safety. By swallowing safety, we mean the food bolus or any particles of the food should not go into the airway or the laryngeal inlet and cause aspiration, because aspiration causes pneumonia. And that, so efficiency and safety are the 2 ways to assess dysphagia. Now, grades of dysphagia. This was about the degrees of dysphagia. The grades of dysphagia can be classified as per the NCCN or Takia classification, or there are other classifications also. I would not be going into the details of each, but what we follow as oncologists is NCCN guidelines, which say there are 4 grades of dysphagia, which divided into swallowing, able to swallow solid in piece whole, swallow in pieces, then swallow only liquids, and unable to swallow anything. Now coming to what causes dysphagia. So dysphagia could be due to because we are talking only about cancer or oncology, I am focusing only on the causes which are related to cancer. So it could be a tumor compression, that is anatomic dysphagia. It could be dysmotility due to the tumor, that is neurologic dysphagia, or it could be iatrogenic, that is you have treated the symptoms of cancer, but due to the surgery or radiation, it has caused more dysphagia, or it has not relieved the dysphagia due to cancer. It has relieved the dysphagia due to cancer, but it has caused the flap related dysphagia or swallowing related dysphagia. So these are the causes. In detail, let us see. The anatomic type of dysphagia, compression, could occur due to luminal, extraluminal or intraluminal. By this I mean, luminal means the tumor is protruding into the lumen and causing the food bolus to not enter into the GI tract easily. The common causes are oral, the large tumor at the base of tongue, epiglottic tumors or the spiniform fossa tumors. Extraluminal tumors are the tumors which occur outside the lumen of the GIT, like in the pharynx we can have large lymph nodes in the neck which compress on the pharynx. We can have large deep parotid tumors which can compress on the pharynx. These are extraluminal tumors which can cause dysphagia. And the third one is luminal. Luminal dysphagias are very less common because usually luminal means there is a thickening in the esophagus which causes dysphagia. But usually luminal converts into intraluminal because there is a protrusion of the tumor into the lumen. The other dysphagia is due to dysmotility due to the tumor. So cancer not only by mechanical obstruction but due to dysmotility can also cause dysphagia. This is rare, only found in 2 to 3% of the cases due to tumor that causes dysmotility. Mainly it is due to mechanical causes. And the third, like I discussed, iatrogenic. So if there is a tumor in the tongue, we do a hemiglossectomy, we put a flap. If there is a tumor in the pharynx, we do a laryngopharyngectomy and we put a PMC or a radial flap, any free flap. That flap might be a bit bulky or that flap is not neurogenic. That means it does not contain the nerves like the nerves which are supplying the normal mucosa or the normal muscles of the pharynx, the sphincters, that are not present in the artificial flap which is taken from the hand or the leg. So that could cause a iatrogenic dysphagia in a form of mechanical obstruction of the flap, or because the flap is not able to move, that might also cause a neurogenic dysphagia due to surgery. The other cause of iatrogenic dysphagia in cancers is radiation. Radiation induces inflammation in any tissue. If we give a radiation of more than 60 to 70 gray in tumors of pharynx, the limit is 60 gray. If we go more than that because the tumor is large or the tumor is not responding, that causes a lot of inflammation, and inflammation, as we all know, leads to mucositis, and mucositis leads to strictures, and that causes iatrogenic dysphagia. So in short, these are the causes of dysphagia due to cancer. Like you can see in this image, these are a few images of my patients, few are taken from the internet. The various causes of dysphagia can be seen on, these are the CT scan images. How to differentiate a CT and MRI is very simple. The bone is bright on a CT scan and the bone is not bright, it will be black or light grey on a MRI. Usually it's black. So these all are images of a CT scan. You can see the mandible very easily here highlighted in each and every image. You can see the spine very easily highlighted here. So this is a CT scan. On CT, the right side is usually on the left and left is on the right. Why we see the CT? Because the CT film is seen from the leg side, from the lower side of the patient. So this is on the left side of the patient. This is a large tumor in the buccal cavity of the patient which is coming intraluminal. This is the tongue, or this is the hard palate area which is pushed. Usually the tongue is pushed towards the opposite side and causes dysphagia. In this image of a CT scan, you can see this is the pharynx. And this tumor is intraluminal tumor at the base of the tongue, and this is causing a pharyngeal dysphagia. In this image, you can easily see there is a tumor which is outside the pharynx. This is the pharynx. In this you can see the tumor is intraluminal. This circle has to be a black circle completely. It has come inside. Here the circle is almost black. It is shortened due to the tumor compression from outside. So this is an example of extraluminal pharyngeal oropharyngeal dysphagia, and it is causing a compression from outside. The fourth image you can see is a tumor at the piriform fossa. So as you can see, this is white image which is just below the mandible is the thyroid or the cricoid cartilage. This is the thyroid cartilage you can see, and this is the tracheal inlet here, and this is the pharyngeal inlet. You can see a tumor in the piriform fossa on the right side which is causing a dysphagia due to a pharyngeal tumor. So this was the oral cavity tumor. This was the oropharynx intraluminal, this was the oropharynx extraluminal, and this is the pharyngeal tumor at the piriform fossa. Below two images are of a CT scan of a thorax, which you can see this is the trachea, very clear cut, it is circular. You can see this esophagus just behind it, and you can see the thickening of the esophagus. Normally, like this, esophagus is very thin, trachea is so thin, esophagus is almost that much thin. There is a thickening, so this is a tumor in the mid-esophagus. Similarly, this is coming to the lower thorax, that is the junction of thorax and abdomen. So this is the liver. You can see a lot of liver mets here. These small circles in the liver are liver metastasis. The tumor is at the lower end of esophagus. You can see the black colored dot, which is the small lumen of the esophagus due to the compression of the tumor at the G junction. So these are the various levels at which dysphagia can occur. It could be oral, it could be oropharyngeal, or it could be esophageal. Now, what investigations we have to do when when a patient comes to us complaining of food is being stuck in the oral cavity or dysphagia? So to rule out anatomic dysphagia, first of all, the most common cause is anatomic. So we rule out anatomic dysphagia. Contrast enhanced CT scan should be done in each and every patient. Please remember, do not do a HRCT if any of your relatives unfortunately has a symptom of dysphagia and you go ahead and you think that CT scan should be done because somewhere I have heard or somebody has done. Please remember, a contrast always should have been done for each and every tumor in the body. Usually a contrast should be there. So contrast CT starting from a skull base up to the thorax has to be done for a complaint of dysphagia. After that, because this is a non-invasive investigation, non-invasive means we are not entering into the body of the patient. So always a non-invasive investigation has to be done first, followed by an invasive investigation. So the second investigation we can see is the upper GI endoscopy, and that is the invasive investigation. So after a contrast CT, if you find there is some tumor, we have to see it and get a biopsy of that tumor. So upper GI endoscopy is done, in which we see the oral cavity, the oropharynx, the esophagus, the stomach, the duodenum first part and up to the second part. All this is covered in the upper GI endoscopy. The third investigation, a barium swallow, usually nowadays is not used for a mechanical obstruction. Previously it was used because good quality CT scans were not available. Nowadays barium swallow is reserved for video fluoroscopy, or as we have some swallowing therapists here, they see the swallowing mechanism or the swallowing physiology using a video fluoroscopy using a barium swallow. That is a very common indication for barium swallow. For mechanical, we do not use barium swallows now. The other cause of neurologic or iatrogenic dysphagia, that is the surgically or radiation induced or neurologic induced, is the dynamic swallowing study, which right now I talked about. This dynamic swallowing study is here done using a barium swallow, in which we give a radio opaque food bolus to the patient in various sizes, various consistency the patient is told to swallow, and a video fluoroscopy is just like an X-ray image done in a dynamic form. That is, dynamic means it's not a simple static X-ray, it is continuously done. So we see the bolus moving from the oral cavity up to the lower end of esophagus, and we see exactly where the tumor is, the bolus is not able to go down. This is not for anatomic, but where the muscles of the GIT are not working. Now a better investigation than a dynamic swallowing study has come up, that is a FEES. Please do not confuse this FEES with FESS. FESS is the investigation done by ENT surgeons to note the nasal cavity and the paranasal sinuses. This is FEES, it's a fiber optic endoscopic evaluation. So it's simple, the terminology says it's all. It's a endoscope which is kept at the level of soft palate, and we see the movement at the oropharynx. The disadvantage of FEES is that because it is only used to see the oropharynx, we cannot see the oral transit phase of the patient, and there is usually head neck cancer patients complain of oral dysphagia rather than oropharyngeal and esophageal dysphagia. FEES is reserved for patients in which oropharyngeal and esophageal dysphagia is there. And the third investigation, not usually for tumors but done for dysphagias of other causes other than tumors, is esophageal manometry. Causes like achalasia cardia can be diagnosed with esophageal manometry. Now coming to the last part of my presentation, I was told that you have been given 20 minutes, so I was a bit quick. So the management is, we usually do not treat cancer, we have to treat a patient as a whole, as we all know. So not only a surgeon or not only a radiation oncologist is required, we need nutritionists, we need physiotherapists, we need swallowing therapists, we need prosthodontics to treat a head neck cancer or a oropharyngeal cancer patient. So one by one, let us see what is the management of dysphagia. Dysphagia management could be divided into three forms for simplification purposes. It could be curative, it could be palliative, and it could be supportive. Curative, like we have oral cancer patients, we have oropharyngeal, we have esophageal cancer patients, in which the surgeries which we do, I have highlighted in next slides, each of them, that surgery is curative. Radiation could be used for curation or palliation alone. For palliation alone, endoscopic stenting or other forms also I have discussed in future slides. And the supportive care is given by the most important people, the nutritionists and the prosthodontics people, swallowing therapists. So one by one, let us see in short what each of these means. In surgical, like I have highlighted, if the cancer is in the oral cavity, it's from the buccal mucosa, or it's from the tongue, or it's from the palate, which is causing a luminal obstruction, We do a commando surgery, we do a palatectomy, or we do a glossectomy. Usually, these are the common surgeries. For oropharynx, usually the treatment is by radiation, and it's not by surgery. But if at all we have to go ahead, nowadays robots have come ahead, and robotic surgeries have made oropharyngeal surgeries easy. So in that case, oropharyngeal resection could be curative for dysphagia of oropharynx. Laryngopharyngectomy is done for tumors of pharynx. I guess you are aware of the anatomy. Pharynx, the hypopharynx is very very close to the larynx, and if there is a tumor in the hypopharynx, the larynx also has to be removed because the anterior wall of hypopharynx is the posterior wall of larynx, and the blood supply of both are common. Hence, while removing the hypopharyngeal tumors like the piriform fossa, we also have to remove the larynx, and that causes a permanent tracheostomy in the neck, which is a very morbid surgery. So if the patient is in the early stage, we usually prefer radiation. If it is an advanced stage, we prefer surgery for laryngopharyngeal tumors. And the last surgery is esophagectomy. So dysphagia is esophageal, that is the tumor is in the mid or lower esophagus, surgery is advised. If the tumor is in the upper esophagus, surgery is not advised because for any esophageal tumors, we require a 10 cm margin. The length of esophagus is 25 cm total. So if the tumor is in the upper esophagus, we are not able to get an upper margin, and so we prefer a radiation over surgery in upper esophagus. For lower and mid esophagus, surgery is the treatment of choice. The other curative option is radiation. So radiation could be definitive, adjuvant and palliative. What do these three terms mean? So if the patient is coming in an early stage, or if the patient is not fit for surgery, we tell the patient to get radiation alone. In that case, the dose of radiation is very very high. That is called as definitive radiation. That is the only treatment that patient is going to take. That is definitive radiation. Adjuvant radiation means the treatment which is taken after surgery. So when we do a esophagectomy or we do a oral cavity cancer patient, and the tumor is very high grade or the tumor is invasive, we tell the patient to take radiation after surgery. That is called as adjuvant radiation. And palliative radiation means you cannot do anything for the patient but just supportive care. In that case, if there are spinal metastasis, especially the spine causes cord compression, and radiation is a very good option for a patient who has spine mets. 8 grade dose is given for such patients. Now coming to the second option, that is the palliative option, that is endoscopic stenting. We have a lot of gastroenterologists doing nowadays a lot of therapeutic procedures other than only diagnostic, one of which is endoscopic stenting. The stent is a small stent, like we have already heard of angioplasty. The stent goes in, it expands. That is the kind of similar stenting is done in endoscopy. It goes through the tumor and it expands. But the problem with these stents, these are metal stents. They can cause tumor perforation in a long stage. If the patient we know is very very palliative, is not going to live for long, then SEMS stents can be put because the risk of tumor perforation is high in the long term. Other risk is stent migration, that is the stent can go up or below and again can cause tumor obstruction. Nutrition, very very important thing for any patient of dysphagia. I am not going to detail because a lot of evidence speakers are going to speak on it. There are two types, enteral and parenteral, and a combined nutrition. The supportive care which comes up for patients who have been operated or given radiation is post-op management or a post-RT management. So speech swallowing therapists are very important part of this, because the main complaint even after surgery is not able to swallow, like I discussed, due to anatomic obstruction of the flap or inability to move the flap. And the second is the prosthodontics. They do a lot of palatal prosthesis, lot of teeth guide which help the patient to chew and swallow properly. This was all about my presentation. Thank you so much for patiently listening to me.
Why don't you come?
Sir.